Yep. Mm-hmm.
Can we go?
Yes.
Okay. So the prevalence is about 5 to 10% of all congenital heart disease, including the premature infants. The pathology and pathophysiology, it's a normal structure between the pulmonary artery and the descending aorta. And the diameter and the length is the things that determine the magnitude of the shunt left to right. When you have a shunt right to left in cyanosis, you have a long-standing large ductus. This is a picture from the structure connecting the aorta and the pulmonary artery. The clinical manifestations. If you have a small ductus, normally you have asymptomatic patients. If you have large ductus, the patient will present symptoms of congenital heart failure. You will hear a murmur, a continuous murmur, like a machinery murmur in the upper left sternal border or the left infraclavicular. This picture shows the 2 points that you can hear the murmur, and you can hear also a diastolic apical rumble. Congenital heart failure or recurrent pneumonia or both can be developed if the shunt is large. The ECG, when you have a small to moderate defect, you can have a normal ECG to a left ventricular hypertrophy. If you have a large defect, you can have biventricular hypertrophy developing to a right ventricular hypertrophy when you have a pulmonary vascular obstructive disease. About the chest X-ray, if you have a small defect, you can have a normal exam. If you have a large defect, you can have cardiomegaly and increase of the pulmonary vascular marking. When you have the pulmonary vascular obstructive disease, you can have a normal heart size, but you have prominence of the main pulmonary artery and the hilar vessels. Here's a picture of a normal size heart and the other one with an enlarged heart and the enlargement of the pulmonary vasculature. About the echo, you have a 2D echo and the color flow Doppler is the most useful method of diagnostic. You can have a cardiac catheterization. Normally is not indicated if you have an isolated PDA. When you have lesions less than 4 millimeters, you can be closed by coils. And if it's like 4 to 10 millimeters, it can be closed by amplatzer. The complications of the procedure can be embolization, hemolysis, left pulmonary artery stenosis, and aortic occlusion if the coil or the amplatzer go the other way of the ductus. About the medical management, the patient don't have an exercise restriction. Indomethacin is ineffective in term infants. There are some indications from non-surgical closure if the patient have congenital heart failure or failure to thrive, a small PDA with murmur. There's no consensus about silent ductus, not the one that you can hear the murmur. And it's contraindicated when you have pulmonary vascular obstructive disease. Surgical management is reserved to patients without the indication of non-surgical closure. The surgeon will do a ligation and division of the lesion. The incision is left posterolateral thoracotomy without the need of bypass. The mortality is about 0%. And the contraindication is if the patient has pulmonary vascular obstructive disease. There are some differential diagnoses. of the patent ductus arteriosus, like coronary AV fistula, systemic AV fistula, pulmonary AV fistula, venous hum. Sometimes you can have some difficulty when you do the physical exam because of the murmurs of collaterals, like in coarctation or tetralogy of Fallot. Patients with absence of pulmonary valve, AP window, PA stenosis, and rupture sinus of valsalva aneurysm.
And we will talk about patent ductus arteriosus in preterm neonates. The prevalence of PDA in neonates depends on weight. About 45% of infants with less than 1.75 kilos will present the PDA, and about 8% of infants with less than 1.2 kilos will present the PDA. And the cardiac heart failure will occur in about 50% of the patients with this lesion. It's a disease related with hyaline membrane disease. We should suspect in newborns responsiveness to oxygen, and if the PGA remains patent with a large shunt left to right, we will see lung stiff. Other aspect that we should see, it's the weaning from ventilator or oxygen therapy becomes when the oxygen therapy becoming difficulty in the patient. For that patients that have a large PGA, we have a rise risk of bronchopulmonary dysplasia and pulmonary hypertension. Weaning from ventilator is one of our difficulties in this population of patients. We can see episodes of apnea and bradycardia when the patients are not in ventilator. As clinical evaluation, we can see bulging peripheral pulses, hyperactive precordion, and tachycardia. All these aspects related with cardiac heart failure. The most common signs that we can see in the physical examination is it's a continuous murmur that we can hear in the area of left intraclavicular and under upper left sternal bone. And the ECG is usually normal. The echocardiogram gives us the most accurate information with anatomic and functional aspects of the heart. The ductal shunts can show us patterns of shunts left-right, bidirectional, or right-left direction. We can take measures of pressure in the PA. We can see the magnitude of ductal shunt and the status of pulmonary perfusion. We can manage as medical management with fluid restriction about 120 ml per kilo, and furosemide about 1-2 milligram per kilo per day. In doses that we will decide, depends on the patient. Indomethacin we can use every 12 hours for 3 doses, and this protocol is more common. And ibuprofen we can use to about 10 milligrams per kilo, followed at 24 hours intervals by 2 doses of 5 milligrams per kilo. Ibuprofen shows us most safe to treat these patients because the lower incidence of oliguria and less deleterious effect on cerebral blood flow. And our surgical management is used when the medical treatment is unsuccessful or there is other contraindication for the medical management for use the drugs for the patients. The mortality of surgical management is about 0 to 3%. It's considered a simple procedure. And today we are using with most frequency the minimally invasive thoracoscopy surgery, and mainly in the low birth weight infants. And this is all. Thank you for attention.
Cecilia, I think your mic is not working. There you go.
Okay, can everyone hear me now?
Yes, I can. Yeah.
Okay, thank you. Does anyone have any questions? That was an excellent presentation. I like how you differentiated between the term newborn and the PREM. Does anyone have any questions for Jessica or Pedro? So if you can turn your mic on too and just ask the question versus going through the chat. Okay, so I just need a couple of minutes and we'll go on to the next speaker. So I'll be back in just 2 minutes.
Thank you.